Welcome to Understanding Stroke and Stroke Recovery, a new hope for stroke survivors, families, and caregivers, presented by Dr. Tomoko Kitago of the Burke Neurological Institute. My name is Bree Price, and I would like to welcome you all on behalf of Burke Neurological Institute. Just some housekeeping notes. Please mute your audio and have your cameras off during the presentation. At the end of the presentation, there will be an opportunity for Q&A, or you may use the chat function to type your questions or comments. I'd like to introduce Christine Hughes. She's BNI's Vice President of Institutional Advancement, who with great pleasure will introduce our presenter.
Thank you so much, Bree, and welcome everyone. We're so glad you could join us today. We have 33 people on and we're expecting close to 100. So if we can, again, just keep our mics muted and our video off, it helps to preserve the bandwidth so that everybody can receive the presentation clearly. Thank you. It is with great pleasure that I get to introduce Dr. Tomoko Kitago. She received her MD from Albert Einstein College of Medicine and did her residency in neurology and fellowship in vascular neurology at New York Presbyterian Hospital, Columbia University. She joined the faculty in the Division of Stroke at Columbia University in 2011 and participated as an investigator for several NIH-sponsored clinical trials and trial networks. She joined the Burke Neurological Institute in 2017 as the Director of Human Motor Recovery Laboratory. Her research includes motor recovery after neurological injury and the development of novel rehabilitation strategies to promote neurological recovery. Her studies involve using kinematics to investigate the behavioral changes that occur over the course of recovery after stroke and changes in motor control in response to rehabilitation strategies, including constraint-induced movement therapy and robot-assisted therapy. Her ultimate goal is to incorporate technology and pharmacological approaches to improve neurorehabilitation after stroke and improve patients' quality of life. It's with great honor and privilege and pleasure that I introduce Dr. Kitago.
Hi, everyone. Thank you so much, Christine, for the kind introduction. I'd like to thank all of you today for joining us for our online webinar about stroke and stroke recovery. So I'm a stroke neurologist and a researcher at Burke Neurological Institute. And today I hope I can answer some of the questions you may have about what a stroke is, how it's treated, and how we can help people recover after they have a stroke. So stroke is unfortunately a very common neurological disorder affecting nearly 800,000 people each year in the United States, which means that every 40 seconds, someone has a stroke. It's also the leading cause of long-term physical disability, affecting 7 million chronic stroke survivors. And Burke Neurological Institute, we are dedicated to finding treatments for chronic neurological disabilities. We're committed to helping stroke survivors recover to their full potential, helping them to walk and talk and see and play with their kids and their grandkids again. I'll be telling you about some of the research that we are currently doing at Burke Neurological Institute to enhance recovery after a stroke. But first, let's talk briefly about what a stroke is. There are two different types of stroke. The first, most common type is called an ischemic stroke. And this is due to a blockage in a blood vessel, either by a clot or a plaque. The blockage interrupts blood flow to a certain region of the brain that's supplied by this artery. And this blood flow is needed to supply your brain with oxygen and nutrients to keep your brain cells healthy and functioning. And without that, the brain cells in that region begin to die, and you begin to have symptoms of a stroke. The second kind of stroke is called a hemorrhagic stroke, and this occurs when there's a ruptured blood vessel causing bleeding in or around the brain. So blockages that cause ischemic strokes generally come from one of two conditions. You can have a blood clot or a plaque that develops within one of the blood vessels in the brain and grows large enough to eventually block blood flow. And this is called a thrombotic stroke. Or you can have a clot that forms elsewhere in the body, commonly the heart, and then travels up to the brain, and this is called an embolic stroke. And now the symptoms of a stroke can vary depending on the area of the brain that's affected. Brain is supplied by many different arteries, as you can see here. And on the right side, different colors represent areas of the brain that are supplied by different arteries. And because each of these areas has different functions, you can have different symptoms depending on the area that's affected. So for example, if you have a stroke involving this dark area here in the yellow, this can cause hemiparesis or weakness on one side of your body. Whereas if you have a stroke in the back of the brain in the red region that's supplied by the PCA or the posterior cerebral artery, that can affect your vision on one side. And there are multiple symptoms that you can have after a stroke. The most common ones involve movement, problems with movement of the arm and the hand or the leg. But stroke can also cause problems with bladder control, swallowing, speech, sensation, vision, language, attention, among others. And the majority of patients actually have more than one of these symptoms. So it's important to be able to spot the signs and symptoms of a stroke so you can act quickly if you or someone you know might be having a stroke. So remembering the word FAST, F-A-S-T, will help you remember the signs of a stroke and what to do if you spot these signs. So the F stands for face. So you can ask the person to smile and see if one side of the face is drooping or if they have a crooked smile. The A stands for arm. You can have the person try to lift up both arms and see if one side drifts downwards. The S in FAST stands for speech, and this could be either slurred speech or trouble getting the words out or finding the right words. And finally, T stands for time. So if you or anyone you're with is developing any of these classic signs of a stroke, it's time to call 911. I want to emphasize that rather than trying to drive yourself to the hospital or calling your primary care physician, it's really important that you activate the emergency medical services by calling 911. Because calling an ambulance means that you can start being evaluated by the medical team even on your way to the emergency room.
All right, well, I'll let you go.
So stroke is a medical emergency, just like a heart attack. Time is brain, meaning that the sooner a stroke can be treated, the better the chances of a good outcome, meaning that you may end up with fewer or milder symptoms or perhaps no symptoms at all. So once you arrive at the hospital, you'll generally have a brain scan right away, usually a CT, to see what type of stroke you had because the treatments for ischemic and hemorrhagic stroke are very different. These are examples on a CAT scan of an ischemic and hemorrhagic stroke. So in ischemic stroke, you see this area of darkness called a hypodensity due to the stroke. Whereas in hemorrhagic stroke, you see this obvious bright area, which is the blood. And right now, we have no way to tell for sure whether a stroke is ischemic or hemorrhagic based on your symptoms or examination. So having a brain scan is really critical to determine the next course of treatment. So as I told you before, ischemic stroke happens when a blood clot blocks a blood vessel that supplies blood to the brain. In many patients, by the time that they get to the emergency room, there's an area of the brain that's irreversibly damaged regardless of what we do. And that's called the ischemic core. However, surrounding that core, there's an area of tissue that's at risk that can still be saved if we're able to restore blood flow to that area early. So we know that early restoration of blood flow to this area within the next few minutes to hours can really decrease the size of the stroke and lead to better long-term outcomes. So how do we do this? How do we restore blood flow to this area? So one way is to dissolve the clot using a clot busting medication called TPA, which I'm sure a lot of you are familiar with. This stands for tissue plasminogen activator, and this is given through an IV. Studies have shown that patients who receive TPA are 30% more likely to have minimal to no disability at 3 months compared to people who don't receive this medication. However, the caveat is that it needs to be given early within the first 4.5 hours of symptom onset. So many patients do not get to the hospital in time to receive this treatment. So that's why it's so important that we recognize the signs and symptoms of a stroke right away and call 911. Some patients may also be eligible for a procedure called a mechanical thrombectomy to remove the clot. They would be eligible if they have an occlusion in one of the larger blood vessels that supply the brain. We can then use devices, either stent retrievers or aspiration catheters, to go and grab the clot or suck out the clot that's causing the stroke. And this procedure must also be done early after a stroke. It can be done in certain selected individuals up to 24 hours after the stroke onset. So here's an example of some pictures from a patient who had a successful thrombectomy. These are pictures of arteries in the brain using dye. And on the left-hand side, you see before the procedure, there's a blockage in the artery that the red arrow is pointing to, called the middle cerebral artery. After the procedure, you can see that the artery is now open, and there's restoration blood flow to this entire region that was supplied by that artery. And the patient did well after this. I've told you about some of the advances that have been made in the acute treatment of stroke, but unfortunately, only a small percentage of patients actually qualify for these acute treatments, and they're also not perfect. So what happens next? After the first few days after the stroke, the focus of the treatment really shifts to helping people recover from their stroke. And at least 2/3 of stroke survivors are left with significant enough deficits that they require rehabilitation services after their acute hospitalization. So what does this look like? Well, there are 3 main disciplines involved in stroke rehabilitation. There's physical therapy, there's occupational therapy, and speech therapy. And each of these disciplines has different goals. For example, physical therapists help patients improve their mobility and their balance. Occupational therapists work on activities of daily living, like eating or bathing or dressing. And speech language pathologists can help patients try to communicate in more useful and functional ways. So the good news is that the majority of patients with time and current standard of care do recover to some extent. And this figure here shows a typical trajectory of that recovery. There's a early, more rapid period of recovery, which generally slows down somewhere between 3 or maybe 6 months. However, despite this recovery that takes place, over half of patients after stroke are left with chronic, lifelong impairments that really affect the way that they can function in their day-to-day lives and can reduce the quality of life. So, as you see from this graph, most of the rehabilitation that's currently being offered is early after the stroke, in the first few weeks to months. And once stroke patients reach this chronic phase, there are really not very many options left for them. They've exhausted what the current healthcare system has to offer. So our unique mission at Burke Neurological Institute is to develop new treatments to help chronic stroke survivors. And we want to do this by repairing the brain. So I think many people have been told that after the first few months after a stroke, there's no more potential for recovery. and that you just need to adjust your lifestyle to live with the deficits that you have at that point. However, I think that there's more and more evidence that that's not true, that the brain has remarkable ability to change and learn with experience and practice, something that we call neuroplasticity. So there can be reorganization and rewiring and strengthening of connections to support that recovery, even months or years after a stroke. But it does take a lot of practice, and the recovery takes time. So we know from our own experiences that whether it's learning to play a sport or to play an instrument, that it takes many, many hours of practice. It's not something that we can learn to do within a matter of days or even weeks. And after a stroke, our patients need to be relearning many, many skills. If we consider problems with movement, which are very common after a stroke, we know from animal studies that very high doses of training are effective in improving recovery. But we're talking about hundreds of repetitions a day practicing a particular task. And for stroke patients, the current standard of care is often not giving them high doses of practice. So even in acute rehabilitation, which is considered the most intensive period of rehabilitation that only some people are eligible for, they're getting 3 hours of daily therapy divided into physical, occupational, and speech therapy. And the average length of stay in acute rehab is generally about 14 days, sometimes even shorter than that. And people have also looked at, how many actual repetitions of a task are people doing in a given therapy session? And that number is only about 30. So we're talking about an order of magnitude lower than what has been shown to be effective in some of the animal studies. So we and others have been looking into ways to give higher doses of therapy for our patients. Now, how do we do that? Well, one way is to use longer sessions of practicing different functional tasks. An example of this is the use of constraint-induced movement therapy, or CIMT. Here, there's intensive training of the impaired or affected hand and arm over several hours a day. And this is combined with restraint of the unaffected side. So you can see here that this patient is wearing a mitt on their good hand to really force use of the impaired arm in doing activities of daily living. The signature protocol for CIMT is highly intensive. It's 6 hours a day for 10 consecutive weekdays and wearing of the mitt for the majority of waking hours. As studies have shown the benefit of CIMT in improving arm and hand function, the problem is that it's very labor intensive and costly. And because of that, it's not being offered at very many places. So another way that we've been exploring to give higher doses is by using technologies such as robotic training devices. In a typical training session with this robot shown here, patients can perform over 1,000 movements in the course of an hour, compared to the 30 that I told you that patients are usually making in a typical conventional occupational therapy session. And these types of devices are also attractive because they can be paired with a video game that can incorporate goals and rewards that make the therapy more motivating and engaging, which is really important for learning. And now there are a variety of different rehabilitation training robots that are commercially available. There are some that are focused on the upper extremity, the hand and the arm function, whereas others are targeting walking ability and leg movements. But even with these newer technologies and higher doses of training, the amount of improvement that we see can sometimes be quite limited. So we're also interested to see whether we can further promote recovery using interventions that stimulate neuroplasticity. So if you remember, neuroplasticity is the brain's ability to change with experience. So 2 ways that are currently being investigated to do that is the use of brain or nerve stimulation, and also the use of drugs that are known to affect neuroplasticity. I just want to give you a few examples. So one type of stimulation that has been in the news recently is VNS, or vagus nerve stimulation. So in August of this year, the FDA approved a first of its kind vagus nerve stimulation system to treat upper extremity motor deficits that are associated with chronic ischemic stroke. So how does this work? Well, the vagus nerve has many functions and connections to various organs throughout the body. In fact, it derives its name, vagus, from wanderer. And through its connections to the brain, activation of the vagus nerve can cause the release of chemicals called neurotransmitters that can increase or decrease plasticity. And when the release of these neurotransmitters is paired with movement practice, the thought is that it can strengthen the connections that are being used to produce that movement by the brain. So the device that was recently approved by the FDA is an implantable device, meaning that it is surgically placed. There's a lead that wraps around the vagus nerve in the neck that's connected to a generator battery that's placed in the upper chest. And then during in-person treatment, the device is wirelessly connected to a laptop computer, and the therapist can manually deliver the stimulation when movements are being practiced. There's also a home version of VNS with this device, where patients can activate the device at home using a magnet and then perform exercises on their own. So Berk Neurological Institute was one of the sites for a clinical trial called VNS Rehab that looked at the safety and efficacy of this system. This trial enrolled patients who had an ischemic stroke between 9 months and 10 years prior to their participation in the study, and who had residual moderate to severe arm weakness. There were over 100 patients who participated in the study overall. And this is a brief schematic of the study design. So everybody who was enrolled in this study had the VNS device implanted. And then they were randomly assigned to one of two groups. One group had the real VNS treatment, meaning that they underwent therapy with their arm and their hand paired with real VNS stimulation. In the control group, they also got the same type of therapy, but they received a sham stimulation. And what this was is that everything was done in the exact same manner as the VNS group, except that the device didn't deliver an actual pulse when the button was pressed or when the magnet was swiped. I think the results of this trial were very exciting. It was a positive trial that demonstrated a benefit of VNS paired with therapy. So these figures here show the change in arm and hand movement from before treatment to after treatment. So the larger values here mean greater improvement. And you can see that the participants in the red group here who received real VNS did better than the control group here in the blue. And this difference was seen immediately after the training on day 1 after the therapy ended, and then persisted out to 3 months after the end of therapy. And then in this last figure here shows the percentage of patients in each group who achieved a clinically meaningful improvement, meaning that they had an improvement that was, that improved their function in everyday activities. And again, you can see here that the VNS group was nearly twice as likely to have these clinically meaningful improvements compared to the control group. So based on the results of this study, the FDA approved this VNS system for stroke. And I think these results also send an important message to patients and clinicians that it's really possible to achieve meaningful improvements even many years out from a stroke. Now, there are other ways that we can stimulate the brain to enhance neuroplasticity in a more non-invasive manner. One such method is called transcranial direct current stimulation, or TDCS. With TDCS, we apply a weak electrical current to the brain to alter its excitability. So in a very simplified model, what happens after a stroke is that the side of the brain that's affected by a stroke has decreased excitability, meaning that those brain cells on that side are less likely to fire. By making them more excitable using this TDCS stimulation, we can make them more likely to fire, more excitable. And the hope is that this will make them more likely to be engaged when performing a movement and lead to greater improvements in their motor performance. So at BNI, we are part of a NIH-sponsored multi-center trial called Transport-2 that examines the efficacy of different doses of TDCS to promote motor recovery. In this study, the TDCS is being given in combination with intensive practice. In this case, a version of constraint-induced movement therapy that I had mentioned previously. So far, the study overall has recruited about the third of participants it had planned, and we are actively enrolling qualified individuals for this study. So if you or someone you know has had a stroke, I want you to think about participating in one of our clinical studies. I think this is an excellent way to help us discover new and effective therapies. And from our patients have cited various reasons that they enjoy participating in our research. First, they like having access to new interventions, contributing to medical knowledge and helping us discover new therapies. You may or may not personally benefit from participation in your study, but you may be helping others, like a friend or a family member who may have a stroke in the future. You'll also be seen by experts in the field who can provide close monitoring of your condition. And research is really how we make progress in bringing new treatments for our patients. And I have to say that as someone who's been practicing neurology for a while, it's really been inspiring to see the treatments that were being tested in clinical trials not too long ago, like mechanical thrombectomy, now being part of standard clinical care and really revolutionizing the treatment for our patients. So I just want to leave you with some ways that you can learn more about clinical research at Burke Neurological Institute. You can sign up for a research registry so that our investigators can contact you about current and future studies for which you're eligible. You can also contact us by phone at our toll-free number, 1-844-NEURO-New York, or email us at clinicalresearch@med.cornell.edu. And all of this information can also be found on our website, which is listed here. And you can also find information about all of the other research that's being done at the Institute, since I only had time today to mention a few. And finally, I want to point out some resources that you may find helpful for finding out information about stroke and clinical trials. So the American Stroke Association and the National Institute of Neurological Disorders and Stroke have informational pages about stroke and treatments and the current research studies that are geared towards patients and caregivers. And the clinicaltrials.gov website has a listing of clinical trials that you can search for by location or by condition, such as stroke. I just searched clinicaltrials.gov this morning and found that there are 370 active trials that mention stroke recovery. So it's a very active area of research worldwide. So with that, I want to thank you all for your attention today. This brings me to the end of my presentation, and I am happy to take any questions that you have.